What should happen at additional meetings of the Protocol Committee? You can schedule the subsequent meetings to accommodate your timeline. At these meetings, each work group may discuss their progress to date. During these meetings, committee members will need to address additional topics to be incorporated into the protocol, including decisions about screening for sexual violence, the components of the medical and forensic evaluation, creation of order sets for medical providers as appropriate, and strategies for protecting patient privacy and confidentiality. When the initial draft is complete, the committee will need to edit it carefully. Whether you do this via email or during one of your meetings is up to you and the group. Keep in mind that busy professionals often do not have time to review documents on their own, so it may be most effective if you review the draft as a group in person. Your committee needs to decide if staff will respond only to known cases of violence, that is, to patients presenting with a history of assault or trafficking, or if they will also screen their patients for sexual violence that has not been disclosed. We know that many children experiencing sexual abuse, assault, and/or trafficking do not spontaneously disclose their experiences, yet they may be in need of support as well as mental and physical health care. This argues for the need to screen patients for possible trauma and/or provide education and resources on sexual violence so a child can disclose their experiences if they choose. The decision about screening requires consideration of several factors, including whether your program is currently using any type of screen which may be supplemented with questions on sexual violence, the time available during the patient visit, your ability to speak to the child alone, the existence of screening tools that have been validated for your patient population, staff training on screening processes, and staff support to provide further assessment and resources for those patients who screen positive for possible sexual violence. Screening for sexual violence may be universal, meaning all patients are screened regardless of age, presenting complaint, or gender. Or it may be targeted, in which only those patients fulfilling certain criteria for high risk are screened. There are multiple screening tools available, as you see on this slide, and this curriculum has links to these tools, but they may or may not have been validated for your patient population. This is an important consideration, especially when contemplating a tool developed in one cultural context for use in another. If there are no validated screening tools for your patients, you may decide to use simple, open-ended questions that touch on potential risk factors, or decide not to conduct screening and instead use the universal education approach. In the latter approach, the health professional spends approximately 5 minutes giving basic information about sexual violence and describing healthy versus unhealthy relationships, often using a brochure like the one seen on this slide. The provider then talks about local and national resources available to those who may have concerns about sexual violence. The provider is not specifically asking the child about their experiences, but is simply offering general education and resources. The child can then choose whether to disclose an abuse experience. They can take the brochure or leave it behind, but they're aware that your facility cares about sexual violence and can provide resources should they need them in the future. The medical providers caring for children who have experienced sexual violence may find it helpful to have electronic order sets that mirror specific components of the protocol. For example, if your protocol dictates that providers contact a social worker when there are concerns of sexual violence, you can make that an item in your order set. Similarly, you can create an order list of sexually transmitted infection tests and potential treatment options. The provider can check off the tests and the treatment choices that are appropriate for their particular patient. If your facility does not have electronic records, you may want to create a cheat sheet that lists the STI tests available and the treatment options. This should be easily accessible as a written or electronic document. The exact items you'll include in your order set or cheat sheet will depend to a certain extent on the decisions you make about testing and the resources available to you. If, for example, you're following the WHO guidelines, you can create a list of the tests and the treatment options described in that document. If you're following the United States CDC guidelines, a checklist is easily made from the chapter on sexual abuse and assault. You will also want to create a flow diagram to map out the entire process of case recognition and response. The group will need to decide how best to incorporate the various steps of the protocol into routine patient care at your facility. That is, you will map out the most efficient algorithm for your busy healthcare setting. For example, if you'll be screening for sexual violence, who will administer the screen and at what point during the visit? Who completes the psychosocial assessment for a victim of assault? And when does it occur during the patient visit? Think about the easiest way you can use existing processes and staff to incorporate the various steps of the protocol. You'll want to minimize disruptions to normal patient flow as you introduce these new guidelines. Your protocol committee will need to develop guidelines about documentation of sensitive information, ensuring patient privacy and maintaining confidentiality. Children and families that experience sexual violence may be very concerned about breaches in confidentiality. For example, they may fear that staff members will share information with outside agencies or discuss their case with other staff members inappropriately. They may fear stigma or negative judgment by providers. Victims may feel intense shame about what has happened to them. The World Health Organization has published ethical principles regarding confidentiality. They recommend that healthcare organizations establish policies regarding record keeping and information sharing that protects patient confidentiality, and that providers be transparent with patient and families about mandatory reporting obligations and other limits to confidentiality. Explanations about confidentiality should be initiated prior to obtaining medical and social histories, before sensitive information is elicited. This allows the patient to decide for themselves what they wish to disclose. Special care should be given when documenting sensitive information in a child's medical record, when there are concerns that an alleged offender may gain access to the record. Documents should be stored securely and information shared on a need-to-know basis only. Staff should not discuss cases with other providers who are not caring for that child, or discuss a case in a public place, such as a stairwell. The provider should obtain consent from the patient, and the guardian as appropriate, before sharing any information that is not part of the mandatory reporting process. All of these issues are important and should be included in your protocol or in a separate policy. In addition, staff should receive training on privacy and confidentiality, and patients and families should have a method of reporting concerns. The organization should monitor staff compliance with policy guidelines. You're almost finished with your protocol. Here are some final steps to consider. You'll want to think about other organizational policies that may need to be referenced in your protocol, or existing policies that may need to be modified to accommodate your protocol. Potentially relevant policies include those addressing the staff response to danger in the workplace, examination of a child when a guardian or parent is not present, or policies outlining methods for patients and families to lodge a complaint. Second, you'll want to identify an emergency contact for staff when they have questions about the sexual violence protocol. Inevitably, unusual circumstances present themselves, and staff need access to a professional, well-trained on the protocol, who can answer questions. Sometimes these questions are related to legal issues, or safety questions, or perhaps clinical decisions. The designated contact needs to have a strategy in place to address staff questions that may be outside their own area of expertise. When your committee has completed the protocol, it's time to obtain formal approval from leadership. Undoubtedly, your institution has established processes for seeking approval, so we're not going to go into that in detail. But just keep in mind how you might garner support for the protocol. You may want to use strategies similar to those you used when lobbying for permission to produce the protocol. Formal approval by leadership is critical, but is not adequate. You also need the support of those who will be using the protocol. Committee members can play an important role here, advocating for the protocol among their colleagues and educating fellow providers on the benefits of the guidelines. Once you have approval to implement the protocol, you'll need to pilot it for a period. During this time, you will actively seek feedback from frontline users. The committee can use this feedback to make necessary adjustments to the protocol. For example, staff may tell you that having the physician screen for sexual violence creates a delay in patient flow, and this delay may be avoided by having the child's nurse administer the screen. When the protocol has been adjusted and is ready for its formal launch, it's helpful to notify stakeholders in the community so they're aware of your organization's initiative and prepared for referrals to their agencies and organizations.